Right, good afternoon, everyone. Welcome to our DS Connect webinar. So I am excited that you are joining us today for our second webinar of 2026. I'll go through just a few housekeeping reminders. First off, please type your questions for Dr. O'Neill during her presentation down in the Q&A box at the bottom of your screen. So we'll answer as many as we can live at the end of Dr. O'Neill's presentation. And those that we aren't able to answer, we will follow up with you and get those answers to you at a later time. So you won't be able to view other participants, and the chat is disabled, just so you're aware of that as well. At this time, I'm going to hand it over to Linda Garcia for just a moment, and she'll go ahead and make sure that our Spanish language participants can connect as well.
Hola a todos, buenas tardes, bienvenidos. Si desea escuchar este seminario web en español, por favor, haga lo siguiente. Presione el icono de interpretación o el mundito que está en la parte inferior de la pantalla y seleccione español. Y para escuchar únicamente al intérprete, seleccione la opción en inglés, Mute Original Audio. Así que esperamos que todos disfruten este webinar. Gracias.
Wonderful. Thanks, Linda. Lindy, are we okay to go ahead?
Yeah, I believe so. Everything's recording and good to go.
Sounds great. Okay. Well, for those of you who are joining us for the first time, we'd like to, we'd like to go through these, have these webinars every once in a while, or quarterly actually, to be able to highlight researchers who have used a DS Connect in different ways, so that participants in DS Connect can understand kind of more what their participation supports. So we'd like to take a few minutes at the beginning of every webinar to tell you a little bit more about new happenings here at DS Connect and highlight upcoming events where you can actually meet the DS Connect team. So as you go through here, I'm showing you a screenshot of our homepage on DS Connect.
I'm sorry to interrupt. I'm not seeing slides.
You're not seeing slides.
Sorry about that.
I'm seeing it on my end, Lindy.
Okay, maybe that's just me then. I will quiet down.
Go ahead and share one more time here. Sorry about that, folks. Can you see the slides now?
I'm seeing it now. Thank you.
Okay, great. So what you're seeing here, hopefully, is a shot of our home screen. And across the top, you'll see these different tabs. And one of the tabs is our upcoming events. And so here, by going here, you can find out where you can connect with the DS Connect team, pardon the pun, over the next coming months. So as you can see, we do have a busy summer coming up. So this is just kind of highlighting June and July. So coming up here in June in Denver, there's the T21 International Research Society, and that actually overlaps with the International Mosaic Down Syndrome Research and Retreat. So DS Connect will be at both of those and can answer any questions for you. This summer also is the Data Science for Developing Scholars in Down Syndrome Research 2-week course, actually. So this is where we support researchers to come out and learn informatics, especially using large data sets. And so this is one way that we can train upcoming scholars to really use the data that we collect through DS Connect to improve the health and lives of individuals with Down syndrome. And then, as you may know, upcoming in July is the National Down Syndrome Congress, the annual convention. So along with that is the Down Syndrome Affiliates in Action meeting and the Global Down Syndrome Foundation Medical Care Roundtable. So DS Connect will have a presence at all of those as well. And this really is our favorite part of the job, is getting out and meeting with the community. And the one thing that we've learned from these events is that it's really nice to be able to talk directly with the community so that it helps drive participation. So really understanding what you're participating in, we know, is very helpful. So with that in mind, we have really kind of launched an initiative to be able to connect with local organizations. So we're calling it Get DS Connected. And in this way, we can come and support, a small community gathering of whatever is of interest to your community. And we've done this at DS Innovations in Kansas City, and we're looking to do it really in more places around the nation. So if you are a member or of a small or medium to large organization that would like to partner, have DS Connect come out, and we can put together a presentation that really works for you and your community, please let us know. Just reach out at info@dsconnect.org, and we'll get back in touch with you. And with that, we will move on to our main presentation with Dr. Meghan O'Neill. Dr. O'Neill is a neurodevelopmental physician at the Lurie Children's Hospital of Chicago. She's an assistant professor of pediatrics at Northwestern University as well. She earned her medical degree at Johns Hopkins University School of Medicine and completed her pediatric residency at Lurie Children's, and then pursued an additional fellowship training in neurodevelopmental disabilities at Kennedy Krieger Institute and Johns Hopkins Hospital. Dr. O'Neill founded the Lurie Children's Down Syndrome Clinic in 2018, and she specializes in the comprehensive care of individuals with Down syndrome, autism, ADHD, intellectual disability, and other neurodevelopmental and neurogenetic conditions. Her research really focuses on the co-occurring neurological, developmental, and behavioral conditions in children with Down syndrome. And she previously served as the medical officer and project scientist for the NIH Conclude project. So with that, I will hand it over to Dr. Lurie for the rest of her presentation.
Great. Thank you, Angela. I'm just going to get my slides going real quick. Okay. All right. And can everyone see my slides okay?
That looks great.
Okay, perfect. All right. Hold on one second. I just have to change one thing about my screen. Okay. All right. So hold on. Sorry. I have something that's getting in the way of my screen. Sorry. It's like blocking the way that I forward the slides. Sorry, guys. Hold on one second. How do I get rid of? Sorry, it's like pulling up the panel and it's like right in the way of my slides. So I'm just trying to figure out how to move it. Okay, that looks like that'll work. All right, sorry about that. So hello everyone and welcome. My name is Dr. Meghan O'Neill, and today we're going to dive into a really important topic, which is autism and Down syndrome. And we're going to talk about how to recognize the signs and support your child. All right. So this talk is a bit time limited, but we have a lot of territory to try to cover about a broad topic. So our goal today is to try to answer some targeted questions here. So I wanted to cover what the difference is between autism and intellectual disability. We wanted to talk about how common autism is in Down syndrome. What does autism look like in a child with Down syndrome? What are the symptoms or kind of red flags that parents should watch for? Why does any of this even matter in terms of making a dual diagnosis? And I think most importantly, what to do next to help support your child. So to set the stage, let's briefly look a little bit at some definitions, because both intellectual disability and autism bring some unique developmental considerations. So when we talk about intellectual disability, so first of all, Down syndrome is the most common genetic cause of intellectual disability. And this really has two core components. So there are challenges with cognitive and intellectual disabilities, so things like problem solving and reasoning. And then there are also challenges with adaptive skills, and that may include things like self-care skills, academics or learning, safety, time management, money management, and things like that. Autism, on the other hand, really is defined by distinct challenges with social communication and interaction, alongside restricted or repetitive patterns of behavior. And so there are specific symptoms or criteria in kind of both of these areas, which we will discuss quite a bit more throughout the talk. when we evaluate a child, we use different tools to investigate the different diagnoses. So we may use cognitive or IQ testing and adaptive testing like the Vineland or the ABAS to really understand the level of intellectual disability, that kind of thing. Whereas for autism, we tend to use more behavior observation tools, things like the ADOS or CARS. So you may have heard of those or seen those discussed, but they're really different tools that get at different things. From here on out, we're going to really try to talk about what happens when individuals with Down syndrome, essentially all of whom have some varying degree of intellectual disability, also have co-occurring symptoms of autism. And that's where things can get a little bit confusing. So co-occurring Down syndrome and autism, so I will probably refer to it as DSASD throughout the talk, but it's much more common than many realize. So there's a variable estimates anywhere from 16 to 39% of children with Down syndrome may carry a dual diagnosis of autism. And this is up to 10 times higher than the rate in the general pediatric population. Despite this prevalence, there's really a quite large average delay of about 4.5 years from the time parents first note concerns to when a child receives a formal diagnosis. And it really does tend to be parents that raise those first concerns. And so the question is, why is there such a gap? And I think, that's pretty complicated as well. I think to start with, there's an entity or something that we call diagnostic overshadowing, and that's where an evaluator may see these developmental differences and mistakenly attribute everything to Down syndrome or intellectual disability alone. And there are overlapping behaviors that both kids with Down syndrome and kids with autism may have. And so sometimes it's kind of tricky to tease out what's what. Overlapping developmental delays can also cloud the picture and make judgment of social skills relative to overall development difficult sometimes. So to really make a diagnosis of autism in kids with Down syndrome, a child's social skills and behavior need to be atypical or sort of lower than what we would expect for their overall developmental level. And that can be really tough sometimes for non-experts to separate out. The other factor that comes into play is that sometimes true discrepancies between social development and overall development don't become really clear until a child reaches an overall developmental level of about 18 to 24 months. And so sometimes it may just take some time to really tease out what's what. And then finally, there really aren't many standardized assessment tools that are normed specifically for the Down syndrome population. But we hope that's something that will change in the future with further research. So in my practice, I find that parents are almost always the first to notice that something's different. They often describe kind of a gut feeling that, my child acts differently from other kids that I've seen with Down syndrome. And some of those common early concerns that prompt families to seek out an official evaluation tend to include things like preoccupying repetitive movements, communication barriers that are really far beyond what we typically see in kids with Down syndrome, behavioral rigidity or self-injury, and then a noticeable kind of pattern of social withdrawal. And so we're going to dive more into the social differences first and then talk a little bit more about other behaviors. So this is a really, really busy table, and I'm not going to go through all of it in detail, but it is a reference that you'll be able to look back with a copy of my slides. But I just wanted to talk about some key differences with social engagement because this is often one of the biggest indicators of autism in this population. So when we think about children who have Down syndrome alone, most kids typically exhibit a pretty high social motivation. They tend to seek out people. They tend to prefer interaction with people over exploring objects and things like that. They tend to connect pretty deeply using eye contact, tend to respond to their names. They share emotions with other people, and they tend to rely a lot on descriptive gestures and imitation to communicate, especially during those early years to kind of compensate for challenges or delays with verbal abilities and spoken language coming in. So all of these skills can still be delayed in children with Down syndrome relative to same-aged peers, but they should be coming in on par with the child's other overall developmental skills. A difference when we look at DSASD, we just see a lot of differences across all of these social aspects. So some of these kids tend to show a preference for solitary play or playing alone. They may seem to kind of be in their own world quite often. Eye contact may be brief or avoidant, and they often don't use eye contact to coordinate attention or to share their emotions or feelings. There's also typically a distinct challenge with gesture use, and they're far less likely to use certain gestures like pointing to an object or bringing it to you to share enjoyment or excitement. And that's a concept we call joint attention. That again it does tend to be delayed in Down syndrome in general, but is even more atypical in kids who have DSASD. These children may not look when their name is called. They may even treat a caregiver's hand like a physical tool to try to get an object rather than engaging with the person directly. And so I think the overall, vibe that you sometimes get in terms of differences is that sometimes children with DSASD seem more interested in objects or sensory experiences and not necessarily for the purposes of bringing that into a social engagement. Whereas kids with Down syndrome alone tend to really prefer that social engagement over many other things. And so, again, if you look at the left-hand column, in all of these different areas, that's where we see quite a few differences. I do think that one thing that's worth pointing out is that kids with DSASD on average do have better reciprocal social interactions compared to kids with autism in the general population. And they also tend to do a better job with imitation and some other social skills. So DSASD also doesn't look exactly like ASD in the general population. And again, that's what can make some of this a little bit tricky. Moving on to behaviors and sensory profiles. So, when thinking about autism, ritualistic behaviors and routine dependence are core symptoms of autism, but they are actually really common among individuals with Down syndrome, with or without autism. So, those are not great symptoms to use in terms of differentiating autism or not autism. Instead, some of the better differentiators are some of the things listed here that fall in the sensory and kind of like repetitive behavior realm. So kids with DSASD can get really stuck in self-directed, repetitive sensory loops, such as visually inspecting fingers or flapping objects back and forth. They may have severe and flexible sensory avoidance towards certain daily tasks. So things like brushing teeth or tolerating specific food textures can be really difficult. We also look for intense motor stereotypies, so like prolonged hand flapping, body rocking, stiffening, things like that, that tend to be preoccupying and really difficult to distract away from. And then finally, we watch for highly restricted, intense focuses. So things like rewinding and fast forwarding a single kind of like 10-second clip of a movie or song over and over and over again, staring continuously at lights, repetitively opening and closing doors or drawers like over and over again. And so, this is not all encompassing, but these are some of the kinds of things that we may see in kids with DSASD. That being said, in general, we always want to focus on the frequency and the intensity of these behaviors and how much they impede daily life. Because at baseline, many individuals with Down syndrome have elevated rates of some of these restricted and repetitive and sensory behaviors compared to same age peers. So it's not just that they are there, it's that they are more frequent, more intense, and more impairing than we might see in other children. Other clues about possible autism include a tendency toward repetitive sensory motor play, without real advancement to functional toy play, without the emergence of kind of like symbolic or pretend play. So this would be maybe a child who's lining up objects, interested in parts of toys or spinning objects or carrying around non-toys, and not really progressing to, playing kitchen or dress up or things like that. We also can see higher rates of self-injurious behaviors. So this can affect about 50% of kids with DSASD compared to about 20% in Down syndrome alone. So we see some differences there. And then there can be developmental regression in kids with DSASD. This is a loss of previously acquired social or communication skills. And we do see this in about 1/3 of children with idiopathic autism in the general population. And that typically occurs around 18 to 24 months. Interestingly, in kids with Down syndrome, we often observe this later, around ages 3 to 7. And that may reflect differences in developmental delays. It may reflect that regression happens at different developmental stages that take longer for kids with Down syndrome to sort of like enter or get through. But this isn't something that we understand very well at all. Finally, functionally, kids with DSASD often experience more profound challenges with their cognitive abilities, with their verbal communication, and with adaptive or kind of everyday life skills compared to kids with Down syndrome alone. So essentially, learning new skills can be a bigger challenge. And that makes sense to some degree because one of the core ways that we learn is from our social engagement with other people by being in tune with our teachers. And that is fundamentally harder for kids who have autism. I'm not going to spend too much time on this slide, but this is a chart that visually shows social communication skills in blue and restricted repetitive behaviors in red for several different groups as measured by the ADOS, which again is a tool that we use to assess for autism. This is broken up into different groups. So there's Down syndrome alone on the left. The two middle groups are DSASD with different cognitive abilities. And then ASD alone is all the way to the right. So the first thing to note is that in general, the DS group alone, all the way to the left, still has elevation of social challenges and restricted repetitive behaviors relative to what we might expect in typical development, where we would generally expect scores of 2 or lower. However, when we look at the DSASD group, they have more symptoms overall, and they demonstrate a little bit of a flatter profile with slight kind of blunting of those social challenges compared to that ASD group alone all the way to the right. They do have more restricted repetitive behaviors compared to Down syndrome alone, but those are about the same as ASD alone. So kind of all in all, I think at the end of the day, this sort of shows that DSASD doesn't look exactly like typical autism. Some of those social difficulties may be a little bit less dramatic than in kids with autism alone in the general population. Finally, another thing that can make diagnostic evaluation really complex is the presence of medical and behavioral co-occurring conditions. So some of these conditions can present with symptoms that would, or could confound the diagnosis. So lack of social engagement and eye contact in kids who have vision problems or cortical visual impairment, lack of social responsiveness in those kids who aren't hearing very well, social withdrawal in kids who are fatigued or irritable related to hypothyroidism or sleep apnea. So all of these conditions can cause or lead to symptoms that in some ways might mimic or look like autism. Beyond these conditions that can kind of cloud the picture, kids with DSASD also have higher incidences of certain medical conditions. So things like infantile spasms and seizures, ADHD symptoms, reflux, constipation, severe feeding aversions, behavioral sleep disorders, and even possibly orthopedic issues. It's rather than these being isolated issues, it's possible that these conditions may stem from the same kind of underlying neurobiological or genetic pathways shared by Down syndrome and autism, but that's something that we don't fully understand, and it really requires further research. I will say that infantile spasms definitely has the strongest association with autism. And so any child that has spasms during, the first year of life typically should be watched really closely for symptoms of autism over time. So all in all, there's some key questions to ask yourself if you're considering whether your loved one might have autism. The first focuses on social interaction and engagement, so whether skills are behind the child's developmental level. The second looks at the extent of restricted and repetitive behaviors and sensory issues, and whether these are pervasive and intense and interfere with everyday life. And then the last thing is whether or not medical issues have also been considered. And if the answer to all of these is yes, then it may be time for an autism evaluation. So, what does a comprehensive, high quality autism evaluation really look like? It really requires a careful multi-step approach because this is a clinical diagnosis. There is no diagnostic blood test, there's no clear biomarker, at least at this point. Although there is some research looking into eye gaze tracking and EEG and other kinds of biomarkers that maybe will change the way that we do some of our evaluations in the future. But right now, everything is very clinical. So the first step is finding the right people or the right team to perform the evaluation. You want a specialist who really understands both autism and Down syndrome. That tends to fall kind of in the realm of developmental behavioral pediatrics or neurodevelopmental disabilities, and sometimes pediatric neuropsychology. Unfortunately, there can be a lot of barriers to accessing this kind of expertise, and I'm sure some of the parents in this group today have experienced this firsthand. In terms of the evaluation itself, first we want to again evaluate for those medical and neurobehavioral confounders, and we just discussed that. Next, we want to really establish a developmental level so that we can know what level of social skills is fair to expect from the child. Third, we want to gather parent and teacher questionnaire data. Although we have to keep in mind that most of these standard checklists that we use in autism aren't specifically validated for Down syndrome. Next, we usually conduct a direct, semi-structured, play-based observation. And the gold standard tends to be the ADOS-2. And that really gives us a lot of information. There are kind of like play-based situations and presses to observe social skills. And so that can be really helpful in getting to know the child's skill level in these when it comes to social skills. And then finally, it all comes down to specialized clinical judgment. So no single test gives the answer. A specialist really has to put the whole puzzle together. So this is a very quick slide and a quick aside, just to kind of mention that scientifically, we are really trying to better understand why the link between Down syndrome and autism is so strong. There's a lot of possibilities. These include overexpression of certain genes that may be involved in autism pathways because of that extra chromosome, an imbalance of the stop and go signals in the brain, which is present in Down syndrome, but is also characteristic in autism. Overactive immune system could be a factor. Differences in the way the brain develops could be a factor, especially the cerebellum. And then finally, the main reason I'm bringing this up is because the child also has all their other chromosomes, and this can contribute to autism. And it raises the question of whether we should be doing additional genetic testing in this population, just like we would when a child in the general population gets a new diagnosis of autism. So I think, these are all, that's a consideration for how we proceed from a clinical standpoint. Okay, so many parents will sometimes ask, why does this even matter? Like, what does autism add to the picture? And essentially, it boils down to improving supports. So a dual diagnosis improves direct access to autism-specific therapies and school interventions and accommodations. It can really shift how we interpret and guide communication and sensory behaviors. And it can improve family stress by helping to kind of align expectations. And then finally, if we recognize autism early, we can start earlier targeted intervention, which we know leads to better outcomes. This graphic here just kind of compares like the standard therapies and interventions that kids with Down syndrome alone tend to get, like speech, occupational and physical therapy, special education, things like that. But when we add in autism to the picture, typically we need or we want to pursue much more in the way of behavior supports, communication supports, and other kind of parent training interventions, which we're going to talk a little bit more about with our subsequent slides. So this slide reviews some autism-specific interventions that individuals with DSASD may have access to that those with Down syndrome alone may not. And that kind of depends on state laws, insurance coverage, and a lot of other complicated factors. In general, interventions like this can be used for skill building, such as improving joint attention, adaptive life skills, social interactions, and communication. And these approaches can be also very effective in addressing challenging or unsafe behaviors. So on the left, we have traditional ABA or applied behavioral analysis. And this is a really highly structured and largely clinician-directed type of therapy. It usually utilizes something called discrete trials training, and that's where skills are broken down into small steps that are done over and over again and taught in a very controlled environment with reinforcers to build specific behaviors. It's really systematic, it's really data-driven, but it can sometimes feel kind of rigid or clinical. The other sort of option out there is naturalistic developmental behavioral interventions, and that's on the right. These are called NDBIs, and these sort of represent an evolution of ABA and are kind of a bridge between behavioral science and natural child development. So NDBIs are not clinician driven, they're really child led, they're relationship driven, and therapy should occur within natural everyday routines. So a therapist or parent would kind of follow the child's natural lead and interests and try to embed learning opportunities right into like everyday activities and play. This tends to shift away from artificial rewards and reinforcers to more natural rewards like shared and social interaction. And they focus a little bit more on building that intrinsic motivation that can be really helpful for developing things like joint attention. In my experience, I do think it tends to be easier to find ABA providers and ABA options compared to NDBIs. But I think that the current is shifting a little bit. There's a lot of controversy about ABA, and autistic individuals who are adults report a lot of distress having gone through ABA. So there's a lot of conflict about that. And realistically, at the end of the day, it's probably that a combination of these approaches may actually be best. The other thing that I usually tell families too is at the end of the day, sometimes the approach doesn't matter as much as it does the people who are doing the therapy and their expertise, their ability to connect to the child and things like that. I'm not going to review this slide in depth, but this just provides some examples of NDBIs. So the kind of the big ones out there are Jasper, the Early Start Denver model, and pivotal response treatment. Jasper actually does have some emerging evidence for use in Down syndrome. And I think in general, all of these therapeutic approaches are pretty intriguing options for future research in Down syndrome specifically. I'm going to kind of move through some of these practical home strategies quickly for the sake of time. But beyond ABA or NDBIs, there are a lot of strategies that can be implemented at home. And this could be a talk in and of itself. For behavior and communication, we want to prioritize visual supports and remember that these kids tend to learn so much better by seeing than by hearing. It really helps to keep spoken language simple, to use predictable visual schedules, to prepare for transitions, to offer choices, and to reduce sensory overload and kind of predict that when we can. And then finally, I think working on proactive functional communication especially with the use of augmentative communication devices, can be really, really helpful. Working with a speech therapist who has special expertise in this area can make a big difference for families and kids with Down syndrome and autism. To build social engagement, we want to recruit those NDBI principles that therapists use. So, stepping into your child's world, joining their play, imitating their actions, and creating opportunities for back and forth connection. We want to be really animated with our facial expressions, pointing and waiting for them to look, and then really celebrating those moments of shared connection. So, there's a lot you can do in everyday play, but sometimes it helps when parents get a little bit of training on how to do this. In terms of school considerations, best placement really does depend on a lot of factors, and schools need to consider a child's autism specific needs. Sometimes those needs can be missed in standard inclusive settings. We always need to ask, is the environment structured? Is it predictable? Are the staff properly trained in autism supports? Are social expectations scaffolded? Is behavior interpreted developmentally? So we want to ensure that staff understand the importance of visual supports, predictability, routine. We want to make sure that there's a focus on social goals in the IEP. And we want to use proactive behavior plans to meet sensory and communication needs. And all of that, all of that parents do tend to have to advocate for. But I think when there's clarity from a dual diagnosis, that can really help educators better understand what kind of supports they need to implement. All right, and then the last slide on supports, or for the sake of time, I'm just going to glide through this, but this is just to point out that direct parent coaching or parent behavior training can be really, really valuable for families. In our clinic, we offer sometimes some Ruby parent training sessions, and I've heard from a lot of families that that was really valuable. There's also there's now more telehealth and kind of on your own options that are out there that have shown effectiveness in research studies. These include things like Project Impact, telehealth pivotal response treatment. And now there's starting to be more like statewide NDBI parent coaching sessions that are integrated into EI. States like Georgia, Texas, and Iowa are kind of piloting programs to do things like that. So there's a few things out there, and then there's self-directed programs that you can kind of do on your own, which are probably not as good as direct parent coaching, but I think they're better than nothing. All right, and then finally, medications. So the main point I wanted to emphasize here is that there are no medications that improve the core symptoms of autism. You may have heard buzz about leucovorin. This is a supplement that can enhance folate levels in the brain theoretically. But at least at my institution, we are not generally recommending this because there's really a lack of rigorous scientific evidence behind this. There's also not really any evidence to support actual cerebral folate deficiency in children with Down syndrome. That being said, there are targeted medications that can sometimes be really helpful to address distressing secondary or associated symptoms. And often it's these symptoms that are more challenging or impairing than the autism symptoms alone. So things like hyperactivity, aggression, anxiety, self-injurious behaviors, and sleep challenges, all of those we have some medications that can help. All right, so we're wrapping up. What should parents do next if they have concerns about autism? So I think first and foremost, trust your observations and your instincts. Collect examples and information that you can share with medical providers because that's really helpful for us. And then spend some time seeking out and finding a place to get a comprehensive evaluation where you know that the evaluators have the expertise needed to make a proper diagnosis. Then comes connecting with specialized service providers and the larger DS-ASD community. And I think finally focusing on support and services, not labels. So just to summarize the talk today, I'll finish with some key takeaways. Autism and Down syndrome is not rare. It is different than intellectual disability alone, and diagnostic overshadowing can be a big issue. Autism is or can look different than Down syndrome alone, and it also can look different than autism alone. But making the diagnosis, I'm sorry, is really important for a lot of reasons. I always try to remind parents that getting an autism diagnosis doesn't change a single thing about who your child is. What it does change is how we understand certain behaviors, how we might access different supports and services, and kind of getting the child the services that they deserve and need. So, an autism diagnosis, I think, for some parents can really come with relief. For other parents, it comes with grief and sadness. But at the end of the day, the ASD label doesn't change anything about a child's worth or potential. But what it can change is sort of the tool set that we have and the roadmap we have to help support a child to meet their full potential. Finally, trust your gut. Remember that you are your child's best advocate and arm yourself with knowledge and ask for support. The last thing I just wanted to finish up with real quick, because this talk is being hosted by DS Connect. I think it's really worth mentioning that looking forward, registries like DS Connect can be a really powerful tool for expanding our understanding of autism and Down syndrome. Right now, most of the research uses clinic-based population samples, and that doesn't always generalize to what we know about the whole population. So by participating, families can really help us build a more comprehensive, inclusive data set, and that can really drive research. There's a lot of questions we could answer if we have larger numbers. And that would include things like validating evaluation tools, figuring out where there's national care gaps, exploring biomarkers. And I think probably most important, if I were a parent, I would probably be most interested in the prospect of clinical trials, especially trials that might examine how effective certain interventions are in kids with DSASD instead of relying on information from the general autism population. With that said, this is just a slide that has some key resources, some websites, and some books that are really great. You can see this on my slide. These are some references, and I think now we have some time for questions.
Wonderful. Thank you so much, Dr. Neal. That was a fantastic presentation.
Yeah.
We do have a number of questions here in the Q&A chat. So I'll just go ahead and start. But so the first one is, how frequently does high functioning or high masking autism occur in Down syndrome? And is that just too hard to tease out?
Yeah, I think that we don't have exact numbers on sort of like those individuals who have a milder level of intellectual disability versus those that have a more severe level. But there definitely do seem to be these two distinct populations. And if you remember back to that chart I had that had the bar graphs, that study actually separated those into two groups. And I have several patients that kind of fall into both groups, but I would say children with more severe cognitive impacts tend to be the majority. And I think the kids with high functioning, high masking autism are probably harder to identify or kind of being overlooked sometimes. But I think they're very and they require sort of a different level of support. And so I think that's something where we do really need a little bit more research on differences between those populations and how best to support each group.
So as a follow-up question, kind of on the other side, how do you know if you're dealing with a Down syndrome autism co-occurring diagnosis or with Down syndrome regression disorder? So
yeah, that's a great question.
Yeah.
And for those who may not know, so Down syndrome regression disorder is it is an entity that seems to be unique to Down syndrome, where there's sort of a loss of skills that happens sometimes acutely, sometimes more subacutely, typically in older children or young adults. And there often is sort of like a catatonia flavor to that. I would say, there's the main differentiating factor in my mind is that autism and the onset of autism symptoms tends to happen much more in the early developmental period. I think that regression that's occurring in like the 3 to 4 range, 3 to 4 year old range, it kind of depends on what you're looking at, but in my experience, a lot of that mimics exactly what we see with autistic regression in the general population. I think when you're moving into these older kids that are approaching the teen years and things like that, that's where it's really tricky. And again, not to sound like a broken record, but I think this is where we need a lot more research. We don't really understand what drives autism and Down syndrome, and we don't fully understand what drives DSRD. And I think, my guess is that there's probably some level of overlap in terms of the neurobiology, and that's something that we need to understand better before we can kind of better understand the treatments for each.
Thank you. Uh, a lot of these questions really do follow onto each other, and a number of families are bringing up questions about late onset autism or late onset diagnosis, specifically teens, 20s, and what other new supports or different supports might be of interest to families there.
Yeah, and so I think it kind of depends on how we're defining late onset autism. If it's something, there's a difference between someone who's diagnosed when they're 9, who always had symptoms, when they had symptoms for a long time, and really it took a while for people to put the puzzle pieces together and actually make the diagnosis. That's much more consistent with kind of like bona fide autism. If it's really a child who was 9, who up until age 9 was developmentally progressing within the range that we would expect for, typical development in Down syndrome, and then had sort of like new onset regression, that's where I think we're probably entering the realm of DSRD a little bit more. And I think any older children who are diagnosed with autism who didn't have earlier symptoms, um, regardless of what we call it, they really do. I think that demands a more thorough neurologic workup in terms of considering things that can cause regression. So there is DSRD, but DSRD is a diagnosis of exclusion. So we would want to do brain imaging. We would want to do an EEG. We would want to do a lumbar puncture to look at cerebral spinal fluid. We might want to do genetic testing. So I think that if it's truly later onset of symptoms, that in my mind as a pediatric neurologist and developmental doctor raises concern that there might be some other entity going on that we need to evaluate further. When these are symptoms that have been always present, or if the regression was early on in toddlerhood, late toddlerhood, that I think is where we tend to progress more, just treating it like we do autism in general. I'm not sure if that answers the question, but
No, I think that it did, and it really does kind of cover quite a scope of different, it really relies on presentation and the history of symptoms is
yeah.
What a lot of people are asking about. So
yeah, and I will just mention, sorry, really quickly,
yeah.
that it is definitely true that after going through regression like DSRD, a lot of individuals do look like they have autism. Like, if someone walked off the street and looked at them, they would think, they have a lot of symptoms that overlap with autism. So I think it's totally all of that makes sense, but it's kind of what underlies that. That's what we don't understand very well.
So that would apply even, the history of symptoms would apply even for milder or missed symptoms that a parent might have noticed. So we're just kind of addressing a question that just came through as well. So we would treat that the same way, or look at that in the same way. There's a lot of interest around NDBI and a lot of additional questions there. I know you talked a little bit about how coverage was state specific. Do you know if it's typically covered by insurance? And where can families find out more about that and access parental support?
Yeah, so it is very, very specific to where you live and your particular insurance plans. I always recommend ABA, like in terms of whether it's ABA or NDBI or whatever it is. I think the first place to start is just talking to your insurance plan about what sort of autism specific supports they do cover. Typically, I don't think it necessarily like matters to them if what it is, as long as the frequency of treatment is not more than they want to cover and that there's an evidence base behind it. But definitely different insurance plans operate in different ways, so it's hard to speak in broad strokes about that. The other thing that I think is sometimes actually even a bigger challenge is finding the places that offer NDBI, because I think ABA has really, at least in my neck of the woods, we're seeing ABA centers pop up everywhere. It's all over the place. And so I think it's not so much that difficult to find ABA providers anymore, but it's the NDBI stuff is trickier to track down. I will say there are a lot more ABA providers who are starting to use a more combined approach where they're a little bit less rigid, a little bit less like clinical, and kind of like working towards more of that like relationship driven approach. And so as I mentioned on that slide, I think sometimes a combination approach is a really good way to go. And I think another way to explore this is if you know that ABA is provided or covered by your insurance, talking to ABA providers and asking them a lot of questions about their approach and whether they do or use some NDBI principles in terms of what they do. And things like Jasper, for instance, Jasper to be certified in Jasper training, you have to have very specific training to be certified to do Jasper. And so sometimes tracking this stuff down is hard. A lot of the different groups have websites. So I believe there's like a Jasper website and these different kinds of therapy where they will often have lists of providers in different areas who are certified to actually give that therapy or do that therapy. And so that's another thing that you can do is reach out to those individuals and ask them like, how do you do this? Do you take my insurance? What's the expense? What's the time commitment? That kind of stuff.
Thank you. Can you talk a little bit, Dr. Neal, about your thoughts on diagnosing autism in an individual with Down syndrome who has significant challenges? So the writer asks about developmental skills under 12 months old in someone who is 9 to 10 years old chronologically. What other considerations should families be looking for there?
Yeah, and I think that's probably like the hardest thing to address, especially as a medical provider, because I think in the medical world, we would often diagnostically say that an individual with developmental skills less than 12 months of age might fall more into like an intellectual disability with autistic features kind of category. That being said, I mean, I will say that at the end of the day, um, it also depends on what you're seeing. If the things that really stand out for this individual are like complete lack of joint attention, no eye contact, just a severe level of those social symptoms across the board, even if you think about a 12-month-old, even a 12-month-old is going to start making eye contact, respond to name, feel socially connected. And so I think there's a way to sort of like justify making a diagnosis. And at the end of the day, there's also sometimes a little bit of a difference between what it medically is like most accurate and also like what's just going to help the family. And so if additional ABA or additional autism specific services would be really beneficial for the individual, I think, sometimes it depends on the person you're working with, but sometimes we can justify why we think autism fits or why the person should receive these services. And quite frankly, there is good data to show that ABA benefits people with Down syndrome alone who don't have autism. And so some of this is also just about like, figuring out how to work with insurance companies and payers to get people what they need to make progress and be successful.
Well put. We have a number of questions about the potential for, triggers or even co-occurring conditions, and one in particular about infantile spasms and the occurrence of later developing autism. Can you talk a little bit about that?
Yeah, so I think we don't really understand exactly how the two relate, but I will say that infantile spasms is a risk factor for autism in the general population, and it's something that we see in Down syndrome as well. I think at the end of the day, there's probably some underlying neurobiological risk that leads to both this atypical seizure and brain connectivity that manifests as infantile spasms. And then that same underlying issue then can lead to autism down the line. We don't understand how to necessarily like modify that. We don't know how to like do anything in terms of infantile spasms to necessarily prevent autism from eventually manifesting. We do think that earlier treatment leads to better outcomes, but we also don't know. We don't have a clear way of necessarily preventing the onset of autism. So in my mind, it's just something that I watch closely. I look for autism symptoms, but I certainly have plenty of kids who have had infantile spasms who do not have autism. So it's not a one-to-one correlation, but it's probably signifying some sort of like shared risk or neurodevelopmental burden based on we would say developmental brain dysfunction from a medical standpoint.
Okay, great. Do you have time for one more question? I think that we're
Sure.
getting towards the end of our time, but we just have a question about if you could speak to some support about added dangers that children with a dual diagnosis might face, like elopement or not understanding safety.
Yeah, so I think safety concerns are a huge issue. And I think the first thing we want to do is kind of like modify the environment as much as possible so that we're preventing access to leaving or access to water or access to the ability to kind of get out. There are a lot of really good safety like toolkits and things like that that have been developed for the autism population at large. So I usually give those safety kits to families when we make a dual diagnosis if safety is a big concern, and kind of fall back on a lot of those strategies. So things like visuals, talking about going through like social stories in terms of why we stay in the room, teaching safety concepts. Sometimes things that sound so ridiculous, like putting a visual stop sign on the door. So every time the child gets there, they think twice. Things like that sound kind of ridiculous, but they can be really effective. And so I usually turn to some of the really good resources that are already out there for autism. And again, it's not even a problem that's necessarily unique to DSASD. We see this a lot in kids with Down syndrome who have ADHD or other like impulsivity. And then sometimes medications for impulsivity can make a big difference. So guanfacine, things like that can be really effective in helping kids kind of maybe calm down a little bit, just reduce that impulsivity, take a second thought before they shoot out the door or do the thing they're thinking about doing. So I think there's a lot of options there, but I think working closely with your provider and exploring those autism resources that are out there can be a really good first step.
That's a great segue. I was just thinking maybe we could do a whole other webinar on it. It sounds like it could cover
Yeah,
a
right.
complete
The
hour
second
and
half
spend
of
some.
this, yeah, the second half of this talk just about like supports for different behaviors and things like that, it could totally be a huge talk in and of itself for sure.
Well, thank you so much, Dr. O'Neill, for joining us. I know there's quite a few thanks and kudos in the chat, so we really appreciate your time. If we didn't get to your question, we'll follow up with you here in the next week or so and make sure that everybody's questions get answered. Again, thanks so much.
Thanks, everyone.
See you next quarter.